Great. So today's webinar is brought to you by Teladoc Health. Teladoc Health is an MHPA Bronze partner and a longtime supporter of MHPA and our health plan members. We thank them for organizing today's session titled Engaging the Hard to Reach Diabetes Management for High-Risk Medicaid Population. I'm excited to welcome today's presenters, Hunter Sinclair and Shannon Stepp, both from Teladoc Health, and Adrian Sovic from Amerigroup. With that, I'll go ahead and turn things over to Hunter.
All right. Well, I appreciate it, Eric, as always. MHPA has been such a great partner for us, and it's a pleasure to be back here talking again about how do we engage with Medicaid beneficiaries. About a year ago, I had the opportunity to moderate another panel where we talked about engaging members, across telehealth and across chronic care services. I'm excited and thrilled to have Adrian here to really talk about one of our Medicaid partnerships with Amerigroup. Some of the results after that first year on the program, again, focusing in on engagement, it continues to be incredibly important, but also getting into the clinical results. How are we changing the lives of the Medicaid beneficiaries that we serve? As in terms of my role, I'm our vice president over government markets, and so I have the privilege of supporting about 60 health plans across Medicare, Medicaid, and Marketplace, really focusing in on how do we meet the unique needs of government health plan members, especially Medicaid members. And even more importantly, working with our internal teams to how do we serve the unique needs of those members in terms of reaching out, engaging, moving the needle on key HEDIS measures or other focus areas. Have been doing this the past 3 years within Teladoc Health. Interesting to join Teladoc during the middle of a pandemic and sort of rapid adoption of virtual care. Before that, had the opportunity to get United, Humana, other health plans driving internal strategy. And then I'm joined by my dear friend and colleague, Shannon Stepp. So Shannon, I'll let you go ahead and introduce yourself.
Great. Thanks so much, Hunter. Hey, everybody. So glad to be here with you all today. Shannon Stepp. I am the Senior Director of Health Plan Strategy here at Teladoc Health. I have been fortunate enough for the past 20 years to be working with health plan partners on the commercial, Medicaid, Medicare Advantage side, all different lines of business, and really building strategies to meet the needs of the members from a holistic health perspective, a virtual care perspective, and ensuring that we're really driving the outcomes that we need to control costs. I have been fortunate enough to be working at Teladoc Health for 10 years, and I spent 15 years at Anthem before that. So thanks so much for your time today, and I would love to pass it over to Adrian to introduce herself.
Thank you, Shannon. And it is such a pleasure to be here. I was just telling them earlier, I have to get in my fall mood because it is still 105 degrees in Texas today, but I'm so happy to be here. My background is in utilization management. I've been lucky enough to be with Elevance since back in 2012. So I started with Texas Medicaid, and I've grown into a regional role where I cover utilization management and case management, also dabbling in long-term care as well. So my passion is virtual care, has been for a couple of years now, and COVID just enhanced that. So this has really been a fantastic journey with Teladoc, and I'm looking forward to sharing our story.
All right. Well, thank you, ladies, and excited to see the attendees continue to grow. I see a lot of familiar friends on there. As a reminder, just in terms of agenda, we want to get into what have been the results. We've been, we always get that question, okay, that book of business is great, but what about Medicaid plans? What are you seeing with Medicaid consumers in particular, especially during a time of redeterminations and a lot of change? A lot of states are, doing new RFPs, going through new procurement rounds. And so we're seeing a lot of sort of, hunger for Medicaid specific stories. So we really wanted to dive in to the results of this program. Again, we want to double click, get a little bit deeper into engagement, what's worked, how could it be even better? What are the ways that we want to continue to expand this relationship? And then where do we go from here? What's next? What's on the horizon, both with Amerigroup as well as just broadly in terms of engaging Medicaid beneficiaries? And then we want to leave enough time on the end for questions. And so, please continue to chat them in. I'll moderate some questions at the end. Make sure you get a chance to hear from Shannon and Adrian. For those of you that aren't familiar with Teladoc Health, we've obviously got to make sure that we introduce ourselves and talk about our Medicaid footprint. I like to talk both geography as well as some of the stats. Everybody asked, have you done it with Medicaid, and have you done it with Medicaid in my state? Increasingly, the answer is yes. We're currently live with over 30 states, multiple MCOs in most of these states. It's actually up to 18 million Medicaid beneficiaries have access to at least one of our services. We had a big expansion with one of our partners last month, and so it's trying to keep up with that growth, making sure we're meeting those unique needs from a regulatory as well as an access perspective. About 50 Medicaid, unique different state-based partners, and about 50% of the Medicaid partners of the Medicaid market is represented by one of our partners. And so have a lot of breadth, but obviously we focus very deeply on partnerships. And that's why we're excited to, I wanted to make sure that it was both Shannon and Adrian, because Shannon, you work every day with your health plan partners. Would love for you to share a little bit more about what are they coming to you for, and what are some of the unique value drivers that you focus in on day in and day out?
Yeah, great question, Hunter. And just so happy to be sharing this with you guys today, and grateful for Adrian to be on here for a true partnership. What you'll hopefully hear today more than anything is, number one, how do we really drive the clinical outcomes, and how do we engage this hard to reach population to drive the value that we need to from a clinical perspective, as well as from a health plan perspective, from a cost perspective. And really, how do we do that? We do that in a couple of different ways. I think more importantly than anything, it's collaboration. It's making sure that we are being consultative and collaborative together, and really driving those synergies, understanding the goals of our client. In this situation, it's Amerigroup, and really building a custom solution around your specific needs. It really is a true differentiator here at Teladoc, and something that we're going to be showcasing to you all today. In evaluating the overall value of your program, we really look at kind of two pieces when we talk about chronic care for Medicaid plans: clinical outcomes, and then the health plan value. What we're going to be showcasing today is really how we drive engagement to drive behavior change. And when you're able to drive behavior change for these hard to reach populations, you're going to see, for example, for diabetes program, better blood sugar tracking, better weight management, improved glycemic control, and overall really better mental health and overall satisfaction. And then what does that mean to you as a health partner? It really supports your efforts with gaps in care closure. We're going to dive into that in a little bit, and advancing your HEDIS measures across the board as well. We want to make sure that you're not only driving those clinical outcomes, but of course, then making sure that there's that return on investment as well in the program. One thing I'm most passionate about, much like Adrian just said, is making sure that we're not only reaching hard to reach members, but providing them access to virtual care to address health disparities. And so you're going to see throughout, whether that be a cellular enabled device that we offer our members, or making sure that we have 24/7 remote monitoring to support members in a time of need, we make sure that we reinforce that health plan value back to you. Now that I shared a little bit more about our chronic care kind of key attributes for a Medicaid plan, I'd like to pass it to Adrian to give a little bit of background on Amerigroup and share before we dive more into the program.
Sure. So Amerigroup is actually a managed care organization that's under Elevance Health, which we focus on elevating that whole health. And that's what we're really trying to strive for in these over the past couple of years, is addressing that whole health need. I worked primarily on the Medicaid side, which is 27 states. Not all of those are Amerigroup, but I mainly service Texas and Nebraska. And Texas alone has 1 million of the 11.2 million Medicaid members that we serve. In Texas alone, we have multiple products, which just keeps things interesting. We have Star, Chip Perinate, Star Kids, and Star Plus. So we have a broad variety of Medicaid members that we're looking to serve. And so we're always looking for solutions on how we can better plan with our trends, and see where we can establish a plan to improve our trend data and have a better outcome for our members. So when we partnered with Teladoc, we started in Texas and Nebraska, and now we've actually spread into Kentucky for the Medicaid space, which Teladoc was already existing in the commercial space, which we'll talk about in a moment. But that's just an overview of who we are at Amerigroup.
No, I think that was great, Adrian. And you're starting to get into the, let's get into the meat of the case study, the experience. I want to go back in time though, so I think I was looking this morning, my first email with Adrian's name on it was back in April 2021. A very different time, as people were sort of, we're trying to figure out what this new normal looks like. Virtual care adoption had really taken off. Set the stage for us in terms of what was the problem you were trying to solve. How did you land on diabetes? And then let's talk a little bit more about how you found the Livongo program that's part of Teladoc Health.
So I think what we all faced during the quarantine period was everyone was at home, including our case management team and the members. And so just having any type of successful outreach was pretty limited, and any kind of engagement we could have. We saw our our inpatient, we saw our doctor's visits were going down and our inpatient stays were going up. Sorry about that. So what we really started trying to tackle is how do we get these members into the most appropriate place of care when we can't get them to go to the doctor's office because they're scared to. So we started digging into our data. And what I always stress with my clinical team is to really understand the data and not just take it for what it is. You really need to know what you're looking at. And our company as a whole looks at a lot of our inpatient stays based off of MSDRG, which is a pretty standard way of looking at diagnosis codes. And what we found is that it wasn't really matching up with what we were seeing on our census. And so we went back and redid some of our data with our IT team and had them re-establish it with an APR-DRG, which is more Medicaid specific. It actually looks into scoring of severity of illness and risk of mortality and gives us a little more in-depth look in our trends with our pediatric population and our NICU, thus pulling them out of all of those other trends that we were seeing previously. So we got a much clearer picture of what was going on in our Medicaid environment. And what it actually showed us is we had an increasing trend in type 2 diabetes during COVID, which is not really surprising. But that told us that that's where we needed to put our focus. And we had no solution for that. So our case management team, we are already really, really challenged with having over 1 million members in Texas and having to address everything that the state expects them to address. And then to add any type of diabetes management on top of that to nurses that aren't specifically trained in diabetic education posed another challenge. And so that's when we started thinking outside of the box as to how we could enhance our program to support these members, which would be a win-win situation for the members and for us. If we could get those members the care that they needed for their type 2 diabetes and keep them out of the hospital, then in reality, that would actually decrease other hospitalizations and comorbidities as well. So there was no negative to looking at another solution to support. So we started looking for virtual solutions with diabetes management. And we actually didn't have to look very far. I went to our contracting team and they said, well, we have this program in commercial that's quite successful called Livongo. And so that's how we partnered up with Shannon and Hunter and started having those discussions as far as how we could approach managing this very, very tricky population. So I will pause for a second because I spoke a lot and I have much more to say, but I'll let you talk, Hunter.
Yeah, no, and I actually, Shannon, I'll kick it over to you. I mean, I think that is the benefit of, coming from this commercial perspective, Anthem now Elevance very well. Talk about maybe the broader relationship and how we were able to translate that into this Medicaid specific program.
Yeah, really, really great feedback. And thanks so much for the backstory. I think it resonates with people, right? Because I think when you look across the United States, we're all dealing with the same problems, right? And how do we really make things as easy as possible in this really overstressed environment that we all work in? And how do we help people, right? I mean, that at the end of the day is what we're all trying to do. And so let's leverage what you have in place today and scale that in other lines of business. And so that makes it easier on Adrienne and her team because it cut down the time greater than probably 75%. Because all of the procurement, everything was streamlined because there was a master services agreement in place for one line of business, like Hunter said, for commercial. Well, then you can leverage, understanding obviously each state needs to review different pieces for each of the Medicaid partners that we're fortunate enough to work with, but that's okay. We have all these other pieces already set up and we can go quick, and we have the opportunity to scale quick here at Teladoc. So from that perspective, it kind of all just came together. And so we want to make sure that we're leveraging that to make it as easy as possible on you, the partner.
Yeah, and Adrienne, I think, one of the other things that stood out, it was, you didn't have to, take our word for it in terms of, the book of business, or, what was the sample size? You all had been working with this, I think, since 2016, and so the actuaries had signed off, which can be incredibly important with any health plan, especially these days, looking at the overall analysis. Does the program work? What are some of the results, both financially and clinically? And so I know that was important, just the legal hurdle, not having to do a master services agreement, the less exciting parts of our jobs. But able to sort of build and tailor in for this population. So let's talk about the tailoring. Some organizations, especially commercial, they make this available to every single one of their members living with diabetes. Talk about the approach that you all landed on in terms of how, which members would you target for this program?
Right. So we have to be a little tight with our Medicaid management. And so we had to go ahead and pull some reports to see where that utilization was coming from. And like I said, by us honing in on that trend data, we already had a good idea where the utilization was coming from. So we pulled all of our member-specific information, looked at those top drivers that were really driving those ER visits and inpatient stays, specifically for diabetes or as a comorbidity. And those are the ones that we initially tackled as far as approaching for the Teladoc experience. So we shared that information with Shannon's team, and to make it very simple, that's how we started our approach. There's a lot more to it, but that's how we started our approach.
No, I think that's perfect. So hopefully, for the audience, that sets the stage in terms of what was the problem they were trying to solve, what was the sort of, there'd been this evolution in the market in general, but also within Elevance in terms of, hey, here's a solution that we've adapted for one line of business. Let's not forget Medicaid. Let's see if we can, take things that have worked in other lines of business, apply them for Medicaid, maybe customize the eligibility. Before we go too far, I like to have a little audience participation. And so we've got some polling questions we'll weave in throughout this discussion. And so, one of the questions I have before we get into the specific results with the solution, just hear a little bit more from the audience in terms of what have been some of the virtual solutions you've deployed for a Medicaid population. If you're, assuming that those on this webinar are Medicaid specific, but would love to hear, are you using sort of a 24/7 urgent care, solution or nurse line similar to Teladoc's General Medical? Are you using this to expand access to mental health? Are you doing a similar chronic care, or it might be called a remote patient monitoring program? Have you adapted virtual primary care? I think that's sort of the next frontier with Medicaid plans, or some sort of second opinion, e-consult or other. Would love to hear from you all. And Eric, maybe, give it another 10 seconds for people to respond, but would love to hear feedback from this group in terms of what sort of solutions they're pursuing. All right, let's see the results. So, Adrienne, I'd be interested in your thoughts. I'd say this sort of, is in line with my thinking in terms of about 50% using some sort of nurse line, expanding the capacity of their nurses or their care managers. They can only go so far, especially across a million lives. I'm a little surprised to see mental health was as low as it is. Would expect that to be a little bit higher given some of the adoption we're seeing, especially with adolescent mental health. There just aren't enough bricks and mortar providers. And so we see a lot of interest and sort of, partners rolling out those virtual mental health. It's sort of where I would expect on chronic care. That's really started to change in the last 2 years, where I'm seeing more of these Medicaid plans start to roll out chronic care programs. And then it's surprising to me that chronic care and primary care have the same sort of level of adoption. So appreciate you all indulging the polling questions. We've got a few more along the way. So please vote early, vote often. But Shannon, let's go in and talk results. We're about a year in. This is a population where we'll talk about we've continued to expand the ways that we can reach out, driving more enrollment in the program. But what are some of the key results that you want to point to? And then Adrian, we'll kick it over to you for your feedback.
Yeah, so we thought it'd be helpful just to start at a high level. Again, thanks so much, Hunter, for teeing that up. We're just at a year mark, so again, early, but not too early. We want to talk about what the results have been so far, and then I think what Adrian and I are most excited about is really talking about how do we customize the solution to drive the appropriate engagement, because we know that drives the outcomes. So we're very excited to say that again, for a Medicaid population, the enrollment rate was at 25%. This is in line with some commercial books of business, so we're really excited about that and excited about sharing how we really use different levers in order to get the appropriate engagement that we needed to get for this hard to reach population. I think one of the biggest takeaways, if I could give you one, is at Teladoc, excuse me, and in our partnership, it's not a cookie cutter approach. We need to customize the solution and customize the engagement journey to meet the needs of the different populations. So that's how we were able to attain the 25%. Also excited, obviously, engagement hopefully then drives outcomes. Pleased to see that the percent of members that had A1C less than 8 has jumped over 20 percentage points. Or a 42% increase after being enrolled in the program for 6 months. So again, how do we really look at longevity? How do we make sure that the results are sustainable? We measure that over time, and we keep looking at data in order to make sure we're hitting our numbers. I also wanted to point out that the members that came in the program were more sick, as Adrian had said. So those that had an A1C greater than 10, more than halved by being engaged into the program as well. And last but not least, obviously, you'll look at average reduction of a 0.8% of A1C for those members that started with an A1C greater than 7. So again, making sure that we're hitting those clinical outcomes. Near and dear to my heart, before I pass it to Adrian, is if people don't love the program, people aren't going to use the program. At Teladoc, we really pride ourselves in a very high NPS score. This is truly phenomenal, plus 69 for the Medicaid members that were enrolled in the program. They love the program, they would refer the program, and you'll see today they really utilize the program. I want to pause for a minute, though. I thought it'd be helpful, Adrian, if you just kind of shared some of the learnings. I think that's one of the greatest parts of our partnership is that we're looking at data, we're sharing, collaborating, and we're learning, and we're pivoting as we go. So just want to see if you want to share any of your learnings as we went throughout our journey together.
Gosh, and I think that's actually just kind of how the virtual journey has gone. When Hunter did that poll a second ago, I was thinking, wow, like 10 years ago, I would have never thought that I would have talked to a doctor well, actually, I wouldn't have talked face to face with anyone on a phone 10 years ago, I don't think, but, with a doctor, to say the least. And now today I'm like, okay, I have pink eye. I don't want to go to the doctor. I just want to show them on my phone and not make myself susceptible to something else. So we've really come so far. And as far as our outreach with Teladoc for these Medicaid members, reaching out to them is a challenge in some ways, but in other ways, they're just like every other person out walking around. We've really gotten to the point where almost everyone has those cell phone capabilities and stuff, which makes it a lot easier. So what we did with this particular program, we started out initially with mail outreach. The challenge with Medicaid is they're very transient and move a lot. And so didn't see as much of a response there, added in phone call outreach that built it up a little bit, and then ultimately added a text outreach. And that's where we got the best response in having all three of those worlds, because every single person responds differently. I know some people prefer to talk on the phone. I prefer to text. I don't have time to talk. So if I get a text, I'm much more likely to respond, but it really depends on the person. And that's how we have to look at our members and how unique they are. And that's where we've seen much better engagement is reaching out to them in the way that they want to be reached.
Yeah, and I know we'll get into it a little bit further, Adrian, but thinking of some of the questions I'm seeing from Amy in the audience in terms of how many members are how are we thinking about eligibility, who might join? I want you to maybe I'll say a quick word about sort of how many members, and then want you to dive into the discharge planning, sort of other ideas you have in terms of like engaging members in this program. But this is sort of low thousands, not tens of thousands. This is about thousands of members that have access to the program, and then we're constantly trying to, it was that high risk population that we targeted, so those that had the emergency department visits, admissions. Adrian, say more about how you're thinking about leveraging discharge planners, other ways that we might engage sort of members at the top of the funnel for this program.
Absolutely. So we started out with a pilot. And so we started small and have worked our way through those lists of members. And so we're already at the point of looking at how can we expand this further, kind of loosen up our search criteria some. And one of the other ways we're looking at in Texas, we have a special program called discharge planning. It's tied to our utilization management team, and it is a group of nurses that do outreach separate from the nurses, but they do outreach to the facilities and help with any discharge planning needs so that we can ensure that the members have the supplies that they need when they're going out or any of the services that they need. And they can also be prepared ahead of time so that there's no waiting or having the 4 o'clock fire drill on a Friday afternoon. So one of the things we're thinking about is tackling members that are, I shouldn't say tackling, we're not tackling anybody, but approaching those members that are on the census that might not have made it into our search criteria before. And as a prime example, our Medicaid members can change from health plan to health plan every single month if they really want to, or sometimes they're new to the program. If they're new to our health plan, they're not going to show up on our internal data for months. We're waiting on claims data to come in to show those trends. And it could be a really sick individual that's just not showing up anywhere because they're so new. So if our nurses see that from the utilization management side, they can identify those members. Our discharge planners can reach out to them and see if they have interest in the program, and we can get them engaged with Teladoc at that point, and also get them engaged with case management. So that gives us the opportunity to catch some of these members that otherwise we wouldn't see for months down the road.
I love that intervention in terms of it's talking about how do we expand to those that would benefit the most. I think it's great for the members. I come from a family of nurses, and I know I've talked to my mom about just how helpless that feeling is if you're sending somebody home and that there's a chance they're going to be back, that they haven't got their diabetes under control. They don't know how to manage. They don't know how sort of the impact of diet and exercise and medication. And so I think that's where our program can really come in handy, where they're getting feedback in the moment. Every single time they check their blood glucose, they're getting a call from a trained diabetes expert in under 3 minutes. Anytime they have a really dangerously high or dangerously low, if they're saying, oh, I've got a low blood glucose, let me go get some peanut butter. No, that's not a fast acting glucose. Most people are not diabetes experts, they're not clinical, but they need help, whether it's a new diagnosis or something that they may have been living with for years. And so I love that as a partnership opportunity. So, all right, before we get into sort of how members are engaging a little bit more about sort of the program, I'd love to hear from you all in terms of, does what Adrian, mentioned, does that resonate with you? I know we certainly have seen an impact in terms of direct mail for Medicaid. There is a lot of housing instability. There's a lot of moving around, I think nationwide, but especially with Medicaid. Over the last couple of years, the data that plans have isn't always up to date because there haven't been redeterminations for a couple of years. So what channels have you found to be the most effective to reach members? Is it direct mail, telephonic outreach, SMS, care manager outreach, community outreach? What are some of the tools that you are using to reach members? We probably should have put all of the above, but I think that surround sound can be incredibly important in sort of breaking through all the noise. I know I've got, hundreds of unread emails right now. And so just trying to figure out, how do you reach members with a message that's really going to resonate for those that really need a program like this? All right, Eric, maybe 5 more seconds. Let people get the responses in. All right. I think Adrian, the audience is with you. They're on the telephonic outreach SMS. It is interesting. It's not 100%, on all of these. It does seem, some plans have different approaches to telephonic outreach. SMS. I know that even working with Amerigroup, there were a lot of safeguards or guardrails we had to work. Hey, you can only call within a certain time window. You got to make sure you're doing all of these. Check the box on these areas, reviewing of scripts, and it can be hard. But it can be effective, as we'll see momentarily. So let's talk about how engagement has sort of gone over time. What are some of the levers we've pulled, and how does it match in terms of your expectations? So Adrian, I'll kick it over to you.
Sure. Well, I think that, over time, like I said, we started small and went big. And once we added all those extra layers, adding the phone, the texting, and the mailing outreach, we more than doubled our enrollment rate. So it really proves that it takes the cumulative efforts to meet our member where they are and to get them engaged. And so I think it's just proof we really do have to hit it from all angles. I also think, and this is totally off the cuff, but I think another place where we are really needing to expand the horizons is actually through app notifications, which we really don't talk about here. But I think that's a really great opportunity to poke a member and get a response that's just yet another layer of how we can engage them. So, but we're coming so far, and this has been a great approach for us.
Yeah, and Shannon, I'll let you chime in. Yeah, I think just one of the comments we've had with the Amerigroup team is, hey, if we just use direct mail, there's going to be a ceiling in terms of what sort of enrollment we'll be able to get. Don't tie a hand behind our back. What are all the channels? What are the ways we can collaborate? We don't want to overload these members. They're getting tons of messages from Amerigroup and others. So how do we manage that? But let us, in a very calibrated way, let us reach out to members in multiple ways. And, we were able to more than double the enrollment rate. But Shannon, what else would you say on sort of the overall enrollment and some of these other ways that, members have been engaging in the program?
Yeah, I'd love to touch on just a piece of the enrollment. I'll talk about the engagement. I think one of the most beautiful pieces of, you don't have to go back, it's okay, no worries, I can speak to it. But one of the most beautiful pieces of the enrollment and the tactics is that it really was a collaboration. It was the best minds at Teladoc and our entire amazing member engagement team collaborating with Adrian and her team, her marketing team, her case management team, going, okay, what do you view as the best practice? This is what we've learned. How do we test, learn, pivot, test, learn, pivot? I think that's the only way that you scale this in a meaningful way and you get the engagement that you need. And so Hunter and Adrian, thanks for sharing kind of that double engagement in recruiting the people to enroll in the program. After you've enrolled in the program, how do you keep the people engaged in the program? So to us, it's really kind of a two-stepped process in that way. You have to get them to agree to participate. But then once they participate, how do you really get them to stay actively engaged? So you'll see on the slide here, thanks so much, Hunter, for being on there. We took a look at the an average 90-day member engagement rates. 82% of the members had device monitoring through that cellular-enabled connected device. Again, phenomenal utilization. They're checking their blood glucose levels. They're making sure that they're being empowered to drive behavior change. And as we said earlier, it ties into that patient feeling better. The high NPS score is about not just the patient satisfaction, but it's about the patient feeling better and taking control of their health. I know Hunter touched on this a little bit earlier, but I kind of just want to talk about one of the things I love the most about the program, and Adrian, you just said this as well, we all like different modes of communication. I also think at different moments of our lives. So I'm a mother of 3 boys and work. And so like Adrian, text is probably great for me a lot, but maybe sometimes I'm being stressed out and I want to talk to a coach. And so there's flexibility within the program to making sure that we're meeting the member to where they want to be met in their journey. And so that could be a self-guided activity. That could be lessons that they're doing virtually online. It could be lessons that they're doing with a coach. So the diabetes certified coach that they're doing one-on-one sessions. One of the great pieces that I love, again, coming from a health plan background, is the summary report sharing. Again, the 80% of these members building this activity. From the click of a button on my blood glucose meter, I can send a summary report of my glucose levels to a physician. I can print that out and bring it to the physician. So there's different options to making sure that we're holistically managing the member and we're making things easier for them and removing those barriers. Again, I talked about it a little bit ago, but the 64% that are engaging in the digital coaching with the nudges, we have different 5-day challenges, food action plans, moving your body action plans, things of that nature, making sure that the members are engaged. And last but not least, the 15%, kind of that alert based on demand. This really is a key differentiator at Teladoc, is having 24/7 real-time diabetes response specialists monitoring for either too high or too low blood glucose. So that is a human that is reaching out to the member, making sure that they're okay. And I think another great feature of the program, and something Adrian's case management team's given a lot of feedback on, is they can always select a friend or family member to also get an outreach, making sure that there's a support system. Hey, your loved one has a low blood glucose reading. You may want to check on them, or too high. And so again, making sure that we're really building a support system for the member to drive behavior change. And then last but not least, I just wanted to call out on the right there. You can read that, but I think this is fascinating. Adrian referenced Texas and Nebraska. Different states and different markets have different unique needs, and some had higher than expected email engagement, and others had higher web portal engagement. So again, learning from that data and customizing the solution. At the end of the day, we want to drive activity and drive empowerment. And for the members that were engaged in the program, they had an average of 19 times a month they had engagement with the program. So again, true testament to driving that engagement after they've enrolled into the program, and making sure that you're learning from that and continuing to iterate as you go along.
I think that's great, Shannon. I think one of the things I've seen is there's often a tragedy of low expectations of, oh, we're not going to do email for Medicaid because it won't work. Well, this is a population that's engaging with us. 80% are opening emails, the 80%, and we have emails for those individuals. So they're using it. I think just making sure that we don't leave behind certain populations with digital because we don't think it works. Often it's not designed well for different populations, but if you make a program that's easy to use, that's providing value, Medicaid populations are going to use it just like other populations are going to use it if you design it well. And then, finally, we want to talk, we've talked, what is the program overall? What are the, different solutions being used? What are the ways of engaging? We want to end talking about clinical and sort of what comes next. And so would love to hear from this group of, what approaches are you using to close important gaps in care? We're talking about a diabetes management, so specifically focused in on A1C control, but would love to hear other thoughts in terms of, are you relying on your provider network, or are you doing things like telephonic outreach or in-home assessments, house calls, a chronic care program like this, maybe at-home lab testing, or some combination of all of the above? All right, so Eric, let's give it 5 seconds, and then we'll see what the group has to say. All right, so I think this is probably not too surprising. A lot of states do require, but heavy on the telephonic outreach, which can be hard. People aren't answering the phone as much anymore. I think there's a question from Jean about the sort of productivity. There's only so many people you can call in a day. Relying on the provider network gets you, part of the way there, but is it really going to help you outperform your competitors that often have the same providers and network? And then it looks like about half are engaging in some sort of program, probably similar to the partnership that we have with Amerigroup. All right, so Shannon, I want you to explain this in terms of how do we look at the clinical results? What have we seen so far? And what are we focused in on? With this sort of high risk, high cost population?
Yeah, thanks so much, Hunter. I mean, I think that we could spend probably hours on different pieces of the clinical outcomes of our partnership, but for the purposes of today, we picked the average reduction and then the percent of members that had an A1C in control. I think the most important piece, and we said this a couple of times, is again that initial pilot that came in that Adrian was sharing. Less than 50% had an A1C in control, and after 6 months, you've seen significant improvement. It was very significant proportion of these members had dangerously high A1Cs. A1C, which we would define as A1C greater than 10. And so to see members with starting A1C greater than 10, a reduction of over 2% is phenomenal, these types of results. I think just as important, obviously, as the average A1C reduction is the percent of members that had A1C in control. So if you look kind of over to the right-hand side, you'll see 45% increase in those with controlled A1C less than 7 when comparing the baseline to 6 months, and a 37% increase with those with an A1C between 7 and 8. We're excited really about we talked a little bit about this earlier, but how to continue to elevate this. How do you keep refining and getting better? I know, not to steal your thunder, Hunter, but moving really to those A1C at-home kits. We're passionate about it here because, again, the more we can remove those barriers, the more we can make things easier for these members to check their blood glucose, to making sure that they're having the appropriate access to care, and they can do a kit right at their home. How do we even get these numbers higher than they already are? But we're super pleased with the great results from a year, and we're excited what next year is going to bring, especially with a lot more program expansion in 2024. So Hunter, let me just pause and just see anything else you'd add to that, or do you want to just dive into the at-home kits?
I think that's well said. I'm seeing a couple of questions come in through the Q&A, so I want to make sure we've got time to get over to those. But Amy had asked a question in terms of how often do you test A1C? And so a couple of ways to answer that. They're regularly checked. It's a blood glucose meter that has cellular connection, unlimited testing supplies. We're able to calculate an estimated A1C based on those blood glucose readings. And we see pretty significant clinical results as early as 3 months. But certainly by 6 months, we're seeing pretty significant behavior change. They're understanding sort of the impact of different diet changes and how that impacts their blood glucose based on the time of day. How does medication have an impact? So we're sort of teaching them how to drive better diabetes management. But you all are health plans. Many of you have withholds tied to A1C control. You need a lab result. And so, there's a lot we can do to nudge members, encourage them to go into their PCP, go into the lab and have an A1C test. We found that only gets you so far. And so back in 2020, when a lot of people were not going into the doctor, we started rolling out the ability to do at-home A1C lab testing. And so worked with the partner. We have the strong engagement. They're checking 19 times a month on average. When you're checking your blood glucose, you are by definition thinking about your health. It's not, you're not bothering them while they're at work, while they're at work or they're in the middle of something else. You're sort of sending them a bidirectional message saying, hey, you're checking your blood glucose. Do you want an A1C kit shipped to your house for no cost to you? Unsurprisingly, when we've done this, across hundreds of thousands of members, 58% said, yeah, sounds good. Let's do it. And then we're able to capture the clinical improvements with 87% having an A1C less than 8. So 5-star level performance for those members. So capturing the clinical benefit with a lab test, making sure that, blood glucose is not enough, that it does need to be a lab test, because if you don't have a lab test, if you can't track it down and it's not in your HEDIS environment, it's as if they have an A1C greater than 9. You're not going to get the credit from that. And so this is something we're also applying with kidney health testing, making sure that members have both the blood and the urine test they need for the new KED HEDIS measure. And so spending a lot of time working with our partners, what are the HEDIS gaps that are most important to you? And how can we use the member engagement, some virtual solutions to really close those gaps in care? Shannon, Adrian, anything that I missed in terms of giving that overview?
Hit it pretty well on the dot. And I just, what I've had to do a lot of education internally with as far as the A1Cs, because it is that we do have a HEDIS gap with reporting these, is an improvement in the A1C is success. So sometimes, like Shannon was saying, they come in and they're just way skyrocket high with their A1C. And so what I've stressed with our non-clinical leaders is, look, they're going down, and that's the direction we want that number to go. And eventually, as we keep them committed in this program, they're going to hit that safe zone for their hemoglobin A1C and have a healthier lifestyle at that point. And we're not only addressing diabetes at that point, they have so many other things going on health-wise, and just managing this and bringing it down is going to show vast improvement in all of those other areas. So it's really a great indicator for us to use.
I think that's well said. Our medical director, I'll channel Dr. Davis, is, diabetes is a progressive condition. Like, things don't get better over time, in terms of it does tend to get worse if it's not managed well. And it can cause, chronic kidney disease and hypertension, sort of all these exacerbating factors. It's rarely that, members are living with just one chronic condition. It's also multiple, and it can have this compounding effect, both physical and mental health. I want to go into closing thoughts. Adrian, Shannon, one of the ones that is top of mind for me would be lessons learned. I'll answer one quick question in terms of what rewards or gamification are we able to offer Medicaid members? And unfortunately, we have not done it in terms of that sort of, we defer to the health plans. Compliance usually says no. I know that some states are more flexible than others. It's something that we do pretty frequently with employer populations, with other lines of business. It can be really effective getting people to enroll in the program, engage in the program frequently, to return an A1C test, or to opt into the program. We've seen that to be incredibly effective. But there's a balance with Medicaid, as you've got to operate in a pretty structured regulatory environment. Make sure that, nothing could be construed in terms of the wrong incentives. But Adrian, have you all done anything creative in terms of incentives or rewards for members?
Specific to this discussion, no. We're very limited on how we can reward our members, and it's, government dollars. So it's always a fine line. I will abstain from saying anything beyond that because it's not technically my area of expertise, but as of today, no, for this particular program.
So dear attendee, the answer is there's no silver bullet. Happy to talk with you about it, but unfortunately, for better or worse, those results are without incentives, which I think is great in terms of we hit our enrollment goal with those incentives, but constantly trying to make sure that it's valuable for the member, even if there's not an Amazon gift card attached. But
And I will say they're getting this glucometer and all the monthly tests, unlimited test strips, which could be a challenge for them in other ways. If they're not going through this program, they might be battling getting their supplies and stuff. So this makes it easier for them, and they've got this nice device. So that's incentive enough for me and feeling better. But I'll leave it at that.
No, I think that's well said. But so, Adrian, what about lessons learned? What do you wish you knew a year ago, 2 years ago, before we were launching this partnership? I know you do a lot of these sort of partnerships.
Yeah, well, just the amount that we've learned through this partnership, our way of approaching the members and outreaching. Had we known that before, would we have more engagement? Quite possibly, and we might be in a different place, but on the positive, had we not taken this baby step to partner with Teladoc, we wouldn't be where we are today. And through all of the learning that and experience we've gone through, with me being in a regional role, it's helped me kind of share those successes with our other Medicaid states. And it's so funny, I refer them over to Shannon quite frequently because they're looking for solutions in their own states. I have 5 other counterparts that are in my similar role. And so we're constantly trying to share these success stories so that we can mimic them in other Medicaid markets and have equal successes. So I would love to say it's a lesson learned, but you can't get anywhere without taking that first step. So I'm just happy to be where we are today with the program.
Yeah.
Stan, what about you?
Yeah, very well said. Obviously echo everything Adrian said. The other 2 pieces that we've really learned, again, is building pieces in that we know that work, like Adrian said. And so, the next state that she had referenced, okay, well, we did things a little bit differently in the beginning there. At-home kits. we're embedding that in. That's a best practice. Let's just have that. I've learned so much with each of the states having to review the agreements, and I know in working, I see all the great folks on. That takes time, right? That takes time. They're busy, the states are busy, and the health plans are busy. And so, how do we expedite things so that when you are ready to launch, when you are ready to go, it's all there? And in addition to that, Hunter, the other piece I'd say is really seeing a lot of states move to this more whole person expansion beyond diabetes. How do you manage someone with diabetes who also has high blood pressure and weight management and mental health? And I know, Hunter, you had referenced that earlier, but how do you really move to this kind of whole person chronic condition management solution? We're seeing a lot of states also be excited about building that in so that when they're ready to go, they can just go and we can leverage those learnings as well.
Yeah, and I think that's an important dynamic on, the states. The regulatory environment for Medicaid can move slower than some of the other states. Teladoc's been around for 20 years. It's the reason we have a lot of telehealth legislation. We were outlawed in Texas. And now, we're expanding in Texas, and, our chief quality officer is, works with the medical board. And so we've seen the environment moved a lot. Sometimes it's not moving quick enough. And so, a lot of times these states are saying, what is this program? How does this work? What does this look like? What sort of plan functions? And so the more reps we have, as we move state by state, that's been really useful. And there's what more can we be doing to really position, demonstrate the program, show how it works, give regulators comfort that, how this program is going to help guide members towards better diabetes care, because we know that the current environment's not working. We've got a lot of members that are unmanaged, not delivering the quality or clinical or financial results that plans are looking for. With that in mind, Adrian, I'd love to hear your thoughts. Like, what else in terms of, where do we go from here in terms of what other outcomes are you most focused on? How do you view success? If we come and we have this webinar again a year from now?
Oh, wow. Well, I'm hoping if we have this webinar a year from now, I probably have one of my counterparts presenting their success story as well. I really feel like, sometimes we're always looking for an external solution, and the solution's already right at home. And with Elevance being such a big company, we had no idea that Teladoc was just behind door number one, in the commercial space. So I'm excited to see us really expand the opportunity and perhaps go. We're just starting with the A1C kits. What's our next step? How can we bring in some of those other needs for the member and address them all under one umbrella? So I say the sky's the limit, and I'm looking forward to seeing what that is.
No, I love that. Love that, Adrian, and love the partnership that we've had with you and sort of the creativity you bring to your role. And I think that's what I'm excited about, seeing more sort of hunger from Medicaid plans of trying new approaches where members have more access, because we see if they have access to more services, they're going to be higher engagement. So we're increasingly seeing plans that will have access to the Teladoc's urgent care 24/7. If they have pink eye, like you mentioned, can they get access? If they want help with mental health, can they actually get in to see a psychiatrist, within 5 days instead of, 60 days? If it's a adolescent, teen, can they get access to a coach, to therapy from the convenience of their home without having to, get out of school and, find time to go in to see a therapist? And so I think there's a lot of virtual care options in general these days, and especially designed for a Medicaid population. And so we're seeing more and more of that adoption. And I think that's going to have this sort of virtuous cycle, driving more sort of market awareness, more member receptivity, and more willingness to try some of these non-bricks and mortar approaches. So we've got about 5 minutes left. Adrian, I know, you're going live on another webinar shortly after this. As we wrap up, any other sort of takeaways, closing thoughts you have for this audience? I know that it's been a pleasure to get to moderate, get to spend time with you two, just working on this partnership. But Adrian, maybe we'll start with you, and then Shannon, have you bring us home.
Absolutely. Well, I want to go back to one of those polls that you took, and the virtual portion was really not touched so much. It looked like for the medical care and the nurse line. So I'm thinking like from my experience, like Live Health Online or the Nurse Helpline or something like that. And I really encourage you all to look beyond those possibilities. We already have a nursing shortage, and so our case managers and team are limited in how much they can give to our members. And so we really have to look beyond those boundaries as far as how we can serve our members best. Our providers, their waiting rooms are packed. And so we have to look at other opportunities to pull out those lower level of cares and address them in the best place possible. And the 24/7 care is another thing we really have to think about. That's how we're going to manage the members the best. And that's really the way of the future, I feel. So I'm just so excited to be part of the journey. And I really appreciate the time today and getting to participate.
All right, what about you?
Yeah, just want to say the same, let us be your partner and let us support you as you're kind of going through the journey. I mean, it's the greatest part of my job is working with clients and partners like Adrian and working with this great team here at Teladoc. And I know from working at a health plan, we can't do all things. You guys, Adrian, just to echo what she said, have your hands full. So I just appreciate the time, appreciate the energy, and look forward to hopefully continue to expand and partner and help support others in the Medicaid space as well. So Hunter, I'll pass it back to you to close.
No, I think that is perfect. We'll appreciate you all joining today. Appreciate the partnership with MHPA and with Amerigroup, and would love to see you all at the national conference coming up in a couple weeks. Hope you have a great rest of your day.
Thanks, everybody.